Well, morning everybody, and thanks very much for joining our session. We wanted to talk to you today about some work we've been doing with hypochlorous acid decontamination and looking at live trials to understand how it works in a real life environment. Si's just actually bringing in a couple of the units that you can see what they look like. So my colleagues, I think I'll have to press this. That's it. So my colleagues here today, I'm Anna Hallas, and I'm a healthcare project specialist working with Compass Medirest. Kate Stone is a senior patient services manager at Sherwood Forest working for Medirest, and Sally Palmer is the nurse consultant and Deputy Dipsy at Sherwood Forest NHS Trust. And this has really been about working in collaboration with the site team, and actually Sally and Kate and the team at Sherwood have done the majority of the work. So just a little bit about us at Medirest. So we partner currently with 20 NHS trusts. We currently employ 10,000 FM colleagues working across the UK, and we offer services in patient catering, cleaning, retail services, portering, logistics, and some wraparound services. So just to give you an idea of what that looks like in terms of scale, we clean about 1.5 million square metres a day. We serve 16,800 patient meals a day. We make 75,000 coffees. Who would we be without getting our morning coffee on our way into work in the morning? We conduct over 6,000 patient surveys, and we serve 45,000 staff and visitor meals a day. So just to give you an idea of the scale. Is this me? Okay.
So just a little overview of what we're going to talk about and what we did with our case study. So I often get asked the question in our organisation, what's your biggest concern at the moment? What keeps you awake at night? And I think over winter, a lot of it was around overcrowding in ED. How are we going to keep those patients as safe as we possibly can? You know, a lot of you probably know some patients were able to hold hands effectively because we'd got that many in our emergency departments. I mean, ours was at times over 3 times capacity as we were trying to get patients in that needed our care. So we looked at what we're currently doing as our current solutions that we've got in the organisation suitable. We use hydrogen peroxide fogging, we use ultraviolet decontamination systems. Obviously these weren't suitable in the ED environment because we can't empty it. There's no way we can get an empty department and move all of our patients out. So it was looking at what can we do? How can we clean our rooms with the limitations that we've got, they're absolutely to capacity. You can barely move around people, so it's really difficult to get in there and clean. So we were looking at new opportunities for how we could support, and Anna and the team brought to us this new innovation to look at in high occupancy areas. So we're quite happy to go with that and have a look, what can we do here? So we put in a process of using the machine to reduce the environmental contamination in our ED department. So we put the machine for this case study in our majors, where we knew that potentially patients were going to be admitted to the organisation. So what we looked at for our monitoring was our respiratory viruses and the hospital-acquired cases. Did we see less hospital-acquired cases whilst we were utilising the new technology? So we put it into our areas. We do AGPs within ED. We have to. We don't know the patient's infectious status when they come into us, so we've got to wait. We don't have a lot of isolation facilities in our ED department. So there's all those things to take into account, and we needed something that was safe to use whilst people were in the environment, and that's what this machine brought us. It was an effective solution that we could use where patients were and in an open environment. The room didn't have to be sealed off. We didn't have to have doors closed or anything like that. And in our ED, we see over 190,000 attendees a year at least, and I know that's going up. Our trust has around 650 beds across 3 hospital sites, a few more in winter when we open our winter capacity. So it was really important to us that we found something as effective as possible. So, back to Anna.
So what is the system that we've used? So as I said earlier, it's a hypochlorous acid using a stabilised solution. It's the system that you see at the side, and it uses a dry mist, which means that it's we're quite able to use it in areas where patients are, which gives us another level of decontamination. So it gives us something else that, the other systems that Sally's talked about, we can only use in the absence of patient. It's proven to eliminate common pathogens, and it's also, because it's cleaning the air, or it's decontaminating the air, it has some residual effect on surfaces as well. As I said, it's safe to use around people, and it's been independently tested. So it was tested at, I believe, Melbeck universities by a UCAS accredited laboratory for the European standards that you see on the list below. Thanks. I'm going to hand you over to Kate, who's going to talk about the trial.
Hello everyone. So before the trial started, we had to get the risk assessments completed from the NHS Trust at Sherwood. So the first few questions they asked was it toxic? No, it isn't toxic at all. The chemical's called BC65, which is a non-toxic biocide, but at the same time it kills 99.9% of pathogens. It's pH neutral, plus the mist is dry, so it isn't any cause to slips or trips. So the risk assessment got completed. The PPE, because it isn't toxic, we didn't have to have any of the extra PPE. It were just the general gloves and apron. So apart from the cleaning, we then looked at what the risk assessment completed. I've done that one. Sorry about that. I hate public speaking, as you can tell. I do. So once the trial was completed and carried out, we then got some questionnaires. It was just 5 simple questions. So the questionnaire was passed to the patients, to visitors and to staff. So it was the simple questions of if they thought it was positive, which 100% of people agreed. Then the smell. The smell, personally, I couldn't smell it whatsoever. But there was 12% who said that it smelled clean. But that were probably because they seen it switched in and it was spraying, so they just assumed it's cleaning, smell clean. 98% of people said they felt comfortable that we, as a trust, was taking extra precautions into stopping the spread of infection, especially straight after COVID outbreaks and everything else. So they thought it was positive. We had a couple of 2% of people who was asking questions, who there were conspiracies of what's spraying out. But that's conspiracies, as we get all of the time. And then 100% of patients agreed that it was a positive step to the future.
I think I missed a slide out, so I'll
Yeah.
tell you about the trial.
Yeah.
So we trialled in ED images, and we do think it's got benefits in other places, but as Sally said, you know, the volume of patients, and we don't know their infection control profile and the length of time that they're staying. We wanted to trial in there, but we also wanted to understand what the outcomes were. So we did a controlled trial from the exact previous 2-month period to the trial period, and Sally will talk us through the results that we got from those 2 identical 2-month periods across the winter. Thanks.
So, the operational feedback. So, I spoke to the domestics who carried out the trial, because the domestics at times can be reluctant to change and to try things, especially people who's done the same clean for years on end. So I gave it to them. I says, give it a try and let's see. The domestics, there was run over. The ease of it, it's a simple touch screen where they've just got to press and it comes on. The lightness of it isn't heavy, it isn't bulky, you can just push it about. And they felt that it was a very simple and effective procedure going into the future.
So just a little bit from, I suppose, from our trust staff perspective, they were a little nervous when we brought the machines in. They were about what this was going to do. They were in those areas for long periods of time, but once that was explained to them, what it was there for, how it would help them as well as helping the patients, they really got on board with it and really supported it. Our communications department did a lot of work around it as well, so they put out staff-wide communications internally, but they also put out some communications on our social media pages just to let patients know before they came in that they may start seeing this new equipment around. It wasn't anything to worry about. It was new for cleaning and decontamination, just to get that word spread so people weren't concerned as they were going into the department. So we did a lot of work around that as well within the organisation. So as Anna mentioned, one of the things that we wanted to do and why we picked Majors is we felt we could get some real data from that around our hospital-acquired respiratory infections. We could really monitor that, and we didn't do any other interventions at that time. We just put this machine in. We'd got our regular PPE in use, as most of you know. Putting masks in isn't always effective because people don't always wear them correctly and things, so that's, you know, we don't just rely on that. So we looked at our flu results, was the main one, and we did see a significant reduction in hospital-acquired flu cases. We dropped from 34% in the previous year to 5% in the same period whilst we were using the machine, which was really good. It's something that we see the extended lengths of stay from patients who acquire flu within the organisation. So we went from 39 hospital-acquired cases to 4 in that period. So that's a significant amount of patients with reduced length of stay whilst they were with us. COVID, we didn't see the percentage reduction because we weren't seeing as many cases of COVID. So it shows that we actually increased in percentage, but the number of cases did actually go down, but our number of cases in general went down that we were identifying during this time. And again, I have to be totally open and honest. We were screening everybody that came through the front door still, because that's what our doctors wanted to do at that time. They've got a really wide criteria of patients, so it wasn't that we were limiting our screening. We were screening a lot more than we would have normally recommended as well with that. We also monitored our RSV cases, and again, we saw a similar picture to flu with the percentage reductions. So it had a really positive impact within our organisation for our patients, because this was the only thing that we did put in place different to previous years. So we found that it was really good. We've got lots of thoughts on what we're going to do this year moving forwards. The machine was in ED all the time, but it wasn't running all the time either. So it runs in cycles. So the team from Medirest would go in and switch it on at different intervals as well. So it was, it wasn't something that we were pumping things out all the time in as well. So that was, and we did have some really good feedback from our teams whilst we were using it.
So we've looked at, so what does this actually mean? Obviously, it's great that we've seen such a fantastic reduction in sort of airborne infection across the trust, but we want to look further at, well, what does this mean in terms of return on investment? So because we use it in ED, we have a 24/7 service in there, so there was no additional labour cost. The machine was housed there. As Sally said, we switched it on. We had 2 periods of an hour a day. Every 12 hours we switched it on, and so these results were just from that period. We looked at the reduction in bed days, so this has really got fantastic clinical benefit because it reduced the bed days significantly. So we estimated the seasonal saving just with the one machine, and for that short trial was 27,500 just based on reduced bed days. And that takes account of the cost of the machine and the cost of the hypochlorous acid that goes into the machines as well. So it really pays for itself over that winter period, and it's really fantastic to get some great data that actually shows the clinical benefit. So we've achieved that ROI within the first winter period. So we hopefully will show that we've demonstrated the effectiveness of the system, and we're certainly going to continue using it and extending it across the use across different sites and in different areas within the site. And we also see this has got benefit wherever you've got multiple patients where you might have airborne infection. So places like endoscopy, where you've got AGPs, open ICUs, neonatal intensive care units, and many other applications. So if you've got a norovirus outbreak, why would you not actually put these machines into a multi-bedded ward? So I think it's got lots of applications, and we really think this is something that will have great benefit to patients at the end of the day. So just the conclusion is, we feel it fills a critical infection control gap. The fact that we can use it where patients are, a bit like Heineken, reaches parts that other decontamination systems don't reach. It has actually impacted the length of stay for patients. So from a patient safety perspective, really powerful. It does allow that safe decontamination in a live environment. So it's got multiple sort of opportunities for use, and I think probably we haven't uncovered all of them yet. So we think it's got a clear infection control and cost benefit, and it boosts confidence. We have developed a case study. At the moment it's just based on ED. That is, further work is going on to actually write that up and actually look at extending that out. We're introducing a further clean type, and we'll keep we'll probably write some papers that we can share and circulate with people as we get more into the technology. But we're really pleased with this technology, and we think it's going to have a great impact on patient safety. Thank you very much for listening.